Thank you for joining us today. My name is Courtney Wilson. I am the president and founder of Fortify Insurance Group, and we are excited to present another thrilling episode of Ask the Doctor. Today, we're going to be talking about one of the most common medical conditions that we run into in insurance, and that is diabetes. There are several different forms of diabetes, but today we're going to be talking about type 2, which is the most common form. Diabetes is a chronic and often progressive disease which presents a very significant issue as it relates to insurance. We run into this very frequently, and today we're going to talk about a specific case that we recently ran into. This was a 57-year-old with a history of diabetes who worked as a software engineer who was looking for individual disability insurance. Now, typically, the first two questions we would ask is if the advisor knows the client's A1C and if perhaps they knew when the client was diagnosed. From there, we can usually get a sense of what's happening, but in this case, we wanted to loop in our medical director, Dr. Chelsea Alvarado, to give us assistance here. Dr. Alvarado, thanks for joining us again today.
Of course, happy to be here. As with most chronic medical conditions, diabetes requires context to understand both the medical stability and the insurance risk. So when we look at a case of diabetes, we consider a few key areas. First is build. As we discussed in prior episodes of Ask the Doctor, obesity independently increases disability risk. So when it is combined with diabetes, that risk compounds. Someone who has obesity and diabetes is at an increased risk of disease progression and cardiovascular complications. Second, we look at the date of diagnosis and their complication history. The longer that somebody has diabetes, the more risk for complications long-term and organ damage, which is permanent damage to one of the organ systems. With diabetes, this happens via blood vessel damage. So we look for signs of microvascular or small vessel disease, which includes diabetic eye, kidney, and nerve disease. And we look for signs of macrovascular disease, which is large vessel, including coronary artery disease and stroke. These complications are not just medically relevant, but they're very relevant to a person's ability to work. So with retinopathy, diabetic eye disease, it impacts someone's visual acuity. It can impact their ability to look at a screen for a long time. With neuropathy, diabetic nerve disease, it can impact someone's ability to balance and their ability to walk, which is very important in many occupations. Then with diabetic kidney disease, nephropathy, this can cause fatigue, making it difficult for somebody to work. And in severe cases, dialysis, which is a very significant morbidity risk. Next, sorry about that, is treatment. With treatment, disability underwriters are looking for how difficult it is for someone to treat their diabetes. So someone who needs insulin is considered higher risk because they have shown signs that their pancreas isn't working as well and that they may have some insulin resistance. Conversely, if somebody is just taking an oral medication, this suggests that their disease is less progressed. Another important factor is the A1C, as Courtney mentioned. The A1C tells us somebody's average blood glucose over the last 3 months. And in most cases of diabetes, in an otherwise healthy non-pregnant person, we want to see that below 7%. Most disability underwriters most favorably want it to be between 5.8 and 6.5%. Last, we look at other cardiovascular risk factors. This includes someone's blood pressure, their lipids, and their smoking status. So in this case, we had a 57-year-old male, 5'9", 160 pounds, with a healthy BMI of 24, a lifelong non-smoker, diagnosed at age 47 with no complications, type 2 diabetes, as Courtney said. His most recent A1C was 6%, and he's treated with metformin 500 milligrams twice daily. He has no other medical problems. Right off the bat, clinically speaking, this profile shows excellent glycemic control. He's got well-controlled A1C, treated only with an oral medication. That tells me that his pancreas is functioning pretty well despite the diabetes, and that his disease has not progressed because he's not shown any signs of complication. The flag here that disability underwriters are going to note is that he has had diabetes for a decade. And as I mentioned before, the longer that somebody has diabetes, the higher their risk of vascular damage. That being said, he hasn't shown any signs of that. So that significantly mitigates the concern and improves the risk profile.
So this looks like a really common type of case scenario that we would run into, right? I mean, somebody that has been diagnosed with diabetes, is taking an oral medication, may or may not be totally in control. But in a case like this, where we've got that, the good cardiovascular profile, we've got, somebody that is, relatively well controlled A1C. What kind of offer do you think we might see in a situation like this?
Yeah. So this is a good case because it's definitely not a decline, but it's also not a standard offer, which is pretty typical in most cases of diabetes with disability insurance. The biggest factors here is that he's had the diabetes for a decade. And so, and he was diagnosed at age 47, which is like on the younger side. So we would expect about a 50% rating in this case, given those factors. Like I mentioned, he's got several protective factors that help this case put us in like the mid rating range. And with that, we would expect around a 5-year benefit period and limited increase riders.
Yeah, and typically, like we said before, the fact that the disease is potentially degenerative over time,
Yeah.
that shorter benefit period makes perfect sense, that we would see that. So I guess at the end of the day, to kind of wrap this thing up, what would the main takeaways for our advisors be, and what should they be looking out for or ask when they run into a client that comes with a similar profile?
Yeah, it's a really great question. I would say to avoid assumptions, when you see somebody that has type 2 or type 1 diabetes, it's really important to ask questions up front. Pre-screening is super important with these cases because if we can see that they, despite having the disease for quite a while, like this client, that they have really good control and that their other risk factors are low, then it really shifts how we think about it and can make the case much more favorable.
I think that's very helpful for most people. As I said, it's one of those things we run into so frequently, that I think it's very helpful, for people to not only understand some of the clinical details of why these insurance companies have to make these changes, but also, what are the things to look out for when you run into these clients. Dr. Alvarado, as always, thanks for joining us today.
Thank you for having me.
Of course. And as always, this podcast is for educational purposes only. We don't intend to provide any medical or insurance advice. And as always, for questions about coverage or clients or any situations that you may run into similar to this one, please do not hesitate to reach out. Thanks again for tuning in, and we'll see you next time.